large bowel. About 22,000 patients are diagnosed with colonic cancer every year. Over the last 4 decades, the 5-year survival rate has improved from 30 to 45%. Regarding the etiology of malignant tumor of the colon, other than the familial or genetic cause like FAB or Hinch syndrome, which is non-polyposis colorectal cancer, there is hypothesis is that increased roughage is associated with the reduced transit time, and in this turn reduce the exposure to mucosa to the carcinogen. All the roughage diet that contain more fiber decrease the risk of colonic cancer. Also, increased dietary animal fat, smoking, alcohol, it is associated with the colorectal cancer. There is some evidence that the link cholecystectomy and therefore increased bile acid secretion to increased risk of colorectal cancer. Adenocarcinoma of the colon, microscopically the neoplasm is columnar cell carcinoma, i.e. it is adenocarcinoma originating in the colonic epithelium. Macroscopically, gross feature of the tumor take 4 forms, either annular, tubular, ulcerative, and cauliflower. Type 4 is the least malignant form. It is likely that a carcinoma starts as adenoma, so-called adenoma carcinoma sequence. These 4 types of the gross type of colorectal cancer: annular, tubular, ulcerative, and cauliflower. This is important because mode of presentation depend on the type of the tumor. For example, annular type presented as obstructive symptoms and early presentation and good prognosis, while the ulcerative form delayed diagnosis because it is presented as anemia of unknown etiology or some sort of bleeding per rectum, which can be attributed to the other cause like anal cause, so the diagnosis will be delayed. Annular variety tend to give rise to the obstructive symptom, whereas the other type present more commonly with bleeding. Tumors are more common in the left colon and rectum. This is the incidence of the tumor within the region of the colon that show about 60% in the rectosigmoid area, which is the most common site of the tumor. The other part of the colon is less frequency. For example, in the ascending colon 5%, in the transverse colon about 5.5%, and descending colon about 4%. Okay. The spread of the carcinoma of the colon take 4 type of spread. First one is local spread. The tumor can spread in longitudinal, transverse, or radial direction. It spread around the intestinal wall and usually cause intestinal obstruction before it invade adjacent structure, while ulcerative type more commonly invade locally, and internal fistula may result, for example, into bladder, colovesical fistulae. Lymphatic spread. Lymph node draining the colon are grouped as follow, and 1 node in the immediate vicinity of the bowel wall, and 2 node arranged along the branches of the superior and inferior mesenteric like ileocolic artery, right colic, mid colic, left colic, and sigmoid arteries. And 3, the apical node around the main branch or main artery, superior and inferior mesenteric vessels, where they arise from the abdominal aorta. Other mode of spread: blood stream spread. Metastases are carried to the liver via portal system, sometime in early stage before clinical or operative evidence is detected, occult hepatic metastasis. The last mode of spread, transcoelomic spread. Rarely colorectal cancer can spread by way of cell dislodgement from the cirrhosis of the bowel to other structure within the peritoneal cavity, causing seeding of the peritoneal cavity. Staging system of colonic cancer. There are several staging systems, but the most familiar or famous one is Duke's tumor node metastasis. All of them can be used in order to predict prognosis and standardized treatment. Duke's classification of the colon as follows: A, B, C, and modification of the Duke's at D. A, confined to the bowel wall. B, the tumor is through the bowel wall but not involving the cirrhosis. C, when there is lymph node. Dukes himself never described D stage, but this is often used to describe either advanced local disease or metastasis to the liver. TNM classification: tumor stage, T1 into submucosa, T2 into muscularis properia, T3 into pericolic fat but not breaching the cirrhosis, and T4 breach cirrhosis or directly involved in another organ. N0, there is no lymph node, and one or two node involved, and N3 N2, 3 or more node involved. M, when there is M0 no metastasis, M when there is distant metastasis. Regarding the clinical feature, carcinoma of the colon usually occur in patients over 50 years old of age, but it is not rare early in adult life. Not surprised when facing a patient, adult or young adult with colon cancer, even in 20 or 30 years old. 20% of cases presented in emergency with intestinal obstruction or peritonitis. Peritonitis because perforation of the tumor site. Those with the first degree relative who have developed colorectal cancer at the age of 45 years or below are at high risk or may be part of the colorectal cancer of familial syndrome like FAB or Lynch syndrome. Carcinoma of the left of the colon. Most tumors occur in this location. About 60% occur in this location. There are usually of the stenosing variety, so the symptom of the increasing intestinal obstruction. This include lower abdominal pain, or may be colicky in nature, and abdominal distension. The patient may have change in the bowel habit with alternating diarrhea and constipation. Carcinoma of the sigmoid. In addition, that symptom of intestinal obstruction, low tumor may give rise to feeling of need for evacuation, which may result in tenesmus, which is painful desire for evacuate, accompanied by passage of the mucus and the blood per annum. Bladder symptoms are not unusual, and sometimes it is herald colovesical fistula. Carcinoma of the transverse colon. This is usually mistaken for carcinoma of the stomach because of position of the tumor together with the anemia and lassitude that produced by this type of tumor. Carcinoma of the cecum and ascending colon. This may be present with the following: anemia, severe and unresponsive to the treatment. The presence of mass in the right iliac fossa. Carcinoma of the cecum can be apex of anticipation, presenting with the symptom of intermittent obstruction. Sometimes the colorectal cancer presented as a metastatic disease. Patient may present for the first time with the liver metastasis and enlarged liver ascites from the carcinomatosis peritoni, and more rarely metastasis to the lung, skin, bone, and brain. Method of investigation of the colonic cancer. The first one is flexible sigmoidoscopy. About 60 cm fiber optic flexible sigmoidoscope is increasingly being used in outpatient clinic or special rectal bleeding clinic. The patient is prepared with disposable enema, and sedation is not usually necessary in sigmoidoscopy. This is particularly useful in supplementing barium investigation, where diagnosis is difficult due to diverticular disease. Diverticular disease sometimes coexists with the tumor, but it is not pre-malignant lesion. Colonoscopy. This is now the investigation of choice if colorectal cancer is suspected, provided the patient is fit enough to undergo the bowel preparation, i.e. when the patient have no intestinal obstruction. It has the advantage of not only picking up the primary tumor, but also having the ability to detect synchronous polyp or even multiple carcinoma, which occur in 5% of cases of colonic cancer. There is synchronous tumor in other site. Ideally, every case should be proved histologically before surgery. Full bowel preparation and sedation are necessary when do colonoscopy. However, one must be aware of small risk of perforation. There is risk of perforation while doing the colonoscopy. Radiology, double contrast barium enema is used when colonoscopy is contraindicated. It shows cancer of colon as a constant irregular filling defect. Ultrasonic is often used as a screening investigation for liver metastasis over the size of 1.5 cm, and CT is used in patients with large palpable abdominal mass to determine local invasion, and particularly used in pelvis in assessment of the rectal cancer, which is effective in picking up polyp down to the size of 6 mm. This may be even replace colonoscopy as the standard investigation in the future. Urogram have a role in left side tumor where there is evidence of hydronephrosis on CT or ultrasound. This is a CT scan that shows a tumor of the right side colon. Treatment, preparation, preoperative preparation. Recent literature has suggested that no bowel preparation is safe for right side colonic surgery, i.e. right side colonic cancer need no preparation. It is regarded as small bowel. The most commonly used method is dietary restriction to the fluid only for 48 hours before surgery. On the day before operation, 2 sachets of Bacloclax, which is Dilcolax, are taken to purge the colon. In addition, a rectal washout may be necessary before surgery. A stoma site is carefully discussed with the stoma care nursing specialist. Anti-embolus stocking are fitted. The patient started on the anti-embolus stocking are fitted. The patient start of prophylactic subcutaneous heparin and intravenous prophylactic antibiotic are given at the start of the surgery. When the intestinal obstruction is present, preparation in this way may precipitate abdominal pain and may be safer to use in on-table lavage technique at the time of the operation. When the abdomen is opened, the tumor assessed for resectability. Liver is palpated for secondary deposit, and the presence of which is not necessarily is a contraindication to resection of the tumor. Peritoneum, particularly the pelvic peritoneum, is inspected for sign of small, white, seed-like neoplastic implantation. The various group of the lymph node that drain involved segment are palpated. The neoplasm is examined with the view to mobility and operability. The operation to be described are designed to remove the primary tumor, and it is draining local regional lymph node, which may be involved by metastasis. Lesser resection are indicated. However, should hepatic metastasis render the condition incurable surgically. There is some evidence that early division of the major blood vessels supplying the involved colon, called no-touch technique. This is Example of the carcinoma of the cecum, the treatment is right hemicolectomy, called right hemicolectomy. While in this area, which is in the sigmoid area or left colonic area, called left hemicolectomy. This is when it's a hepatic flexure of the colon, called extended right hemicolectomy. When the graft is found to be inoperable, in the upper part of the left colon, ileostomy is performed. In the pelvic colon, a left iliac fossa colostomy is preferable. With inoperable growth in ascending colon, a bypass using ileocolic anastomosis is the best procedure to bypass the tumor. That could be, it is a source of intestinal obstruction. Screening of the tumor or the colonic cancer. Regular bowel screening using a fecal occult blood test for people aged about 60 to 69 years can reduce the mortality risk of colorectal cancer by about 15%. Those who test positive for fecal occult blood test are then offered colonoscopy. Flexible sigmoidoscopy can also be used as initial screening test. Other disorder of the colon is trauma. The intestine can be ruptured with or without an external wound, such as blunt trauma. The most common cause of this blew to the abdomen that crushed the bowel against the vertebral column or sacrum. Also, rupture is more likely to occur where the part of the gut has been fixed, for example hernia, or when the fixed part of the gut join a mobile part, such as a DJ flexure. In a small perforation, the mucosa may be prolapsed through the hole and partly seal it, making the ill sign misleading. In addition, there may be laceration in the mesentery. The patient will then have combination of intra-abdominal bleeding and release of intestinal content that into abdominal cavity that give rise to the peritonitis, i.e. acute abdomen, rigid abdomen. Traumatic rupture of the large intestine is much less common. In a blast injury of the abdomen following the denudation of the bump, the pelvic colon is particularly at risk of rupture. Compressed air rupture can follow the dangerous practical joke of turning on the airline carrying compressed air near the victim anus. The last subject is stoma. Stoma is defined as externalization of the viscous to the exterior. Colostomy is defined as artificial opening made in the large bowel to divert feces and flatus to the exterior, where it can be collected in external appliance, depending on the purpose of which the diversion has been necessary. Colostomy may be temporary or permanent. Temporary colostomy, transverse loop colostomy, has in the past been the most common use in dysfunction of the anastomosis after anterior resection of the rectal tumor. It is now less commonly employed as it is fraught with the complication and is difficult to manage. Loop ileostomy is preferred. So loop left iliac fossa colostomy is still sometimes used to prevent fecal peritonitis developing after trauma injury to the rectum or the left colon, to facilitate the operative treatment of high fistula in ano and incontinence. So all these indication for temporary colostomy. It is important to know what is the indication of temporary colostomy. Temporary loop colostomy is made bringing loop of the colon to the surface. It is held in place by a plastic bridge passed through the mesentery. Once the abdomen has been closed, the colostomy is opened. When the firm adhesion of the colostomy to the abdominal has taken place, the plastic bridge can be removed after 7 days. Colostomy closure is most easily and safely accomplished if the stoma is mature, i.e. after the colostomy has been established for 2 months. Permanent colostomy, this is usually formed after excision of the rectum, especially lower rectum, for carcinoma by the abdominoperineal technique. It is formed by bringing the distal end colostomy of the divided colon to the surface in the left iliac fossa. This is the loop colostomy, and between them is plastic bridge. And this is the picture of loop colostomy with appliance of the colostomy base and back. The point at which the colon is brought to the surface must be carefully selected to allow colostomy bag to be applied without impinging on the bony prominence of the anterior superior iliac spine. The base site is usually through the lateral edge of the rectus sheath, 6 cm above and medial to the bony prominence of anterior superior iliac spine. Colostomy bag and appliance. Feces from the permanent colostomy are collected in a disposable adhesive bag. Wide range of such bag is currently available. Many now incorporate a stoma adhesive backing which can be left in place for several days. In most hospitals, a stoma care surface is available to offer advice to the patient to acquaint them with the latest appliances and provide the appropriate psychological and practical help to the patient. Complication of colostomy. The following complication can occur to any colostomy, but are more common after poor technique or sitting of the stoma. The first complication is prolapse, retraction, necrosis of the distal end, fistula formation, proximal fistula proximal to the opening of the colostomy, stenosis of the orifice, colostomy hernia called parastomal hernia, bleeding, which is usually of secondary type due to granuloma around the margin of the colostomy. Colostomy diarrhea, this is usually in the infective enteritis and will respond to oral metronidazole 200 mg 3 times daily. Thank you.